Let's unpack this. Welcome back to the deep dive. Today we're embarking on, well, a really comprehensive journey. We're diving into one of the most vital systems in our body, but one we maybe don't talk about enough. The intricate world of our intestines. We've sifted through a fascinating stack of sources, medical research, patient notes, the whole lot. And our mission, as always, is pretty simple. Pull out the most important insights, give you those real aha moments, and leave you feeling informed, but hopefully not overwhelmed. Think of it like your shortcut guide to understanding everything from common infections to chronic conditions, even some pretty serious surgical interventions that affect your gut. So let's explore what can go wrong, and maybe more importantly, what we can do about it. It's a crucial part of your overall well-being. Let's dive straight into infections. These can often be, well, quite acute, painful, and sometimes, surprisingly, triggered by things we wouldn't expect. Our sources highlight that, many intestinal infections get in through contaminated food or water or just person-to-person contact. Pretty standard stuff. But here's where it gets genuinely interesting, maybe a bit counterintuitive. Let's talk about Clostridium difficile, or C. diff as it's usually called.
Yeah, C. diff is fascinating, clinically speaking. And a critical insight from the sources is that it often takes hold and really thrives after someone's been treated with antibiotics.
After antibiotics, that seems backwards.
Well, think about it. Antibiotics are designed to kill harmful bacteria, right? But they're not always super selective. They can sometimes wipe out the good bacteria in your gut too, the ones that normally keep things in balance.
Okay, so it leaves a gap.
Exactly, an open playing field. C. diff exists as these really resilient spores, and they can survive the antibiotic onslaught. Then, when the competition is gone, they seize the opportunity to multiply and start producing toxins. And this is what leads to quite severe inflammation of the colon, known clinically as antibiotic-associated pseudomembranous colitis, or AAPMC.
Wow.
It's a stark reminder that sometimes a necessary treatment can inadvertently create a whole new problem.
So for someone actually going through this, what are the telltale signs? What does the research point to?
The classic clinical signs are pretty clear. Significant diarrhea is usually the main one, often accompanied by a real sense of rectal urgency, needing to go right now. You might also get tenesmus, that's a painful, kind of ineffective straining, feeling like you need to pass stool even when you can't.
That sounds awful.
It is. Nausea, vomiting, abdominal cramping, bloating, and fever are all common too. It's a serious infection, no doubt about it.
Okay, so that brings up the really important question. How do we manage it once it takes hold?
Right. Well, the first step, if it's possible, is to stop the original antibiotic that likely triggered the C. diff overgrowth in the first place. Then, specific antimicrobial drugs like Flagyl or vancomycin are used to target the C. diff bacteria directly. And crucially, because of the severe diarrhea, replenishing fluids and electrolytes is absolutely vital to combat dehydration.
Makes sense. Any symptom relief?
Yeah, for symptoms, some over-the-counter options can help. Kaopectate can help firm up the stools a bit. Pepto-Bismol might help calm the gut and reduce the sheer volume of diarrhea.
Okay. And what about prevention? You mentioned it's linked to antibiotics, but how do we stop it spreading?
This is maybe the most crucial takeaway, and it's something we think we all know, but the detail matters. Our sources really emphasize hand washing with soap and water is paramount.
Soap and water specifically?
Yes, because, and this is the key point, alcohol-based hand sanitizers are not effective against C. diff spores.
Really? That's huge.
It is. It's a subtle but incredibly important distinction for stopping the spread, especially in hospitals or care settings. And beyond personal hygiene, cleaning equipment rigorously with a bleach solution is also key.
It just underlines how something seemingly simple, like proper hand washing, can have such a massive impact.
Absolutely.
Okay, moving on from those acute infections. Let's explore some chronic conditions. These might be less sudden, but they can really impact daily life over the long haul. Let's start with irritable bowel syndrome, or IBS.
Right, IBS. It's an interesting one because it's mostly considered a functional disorder.
Functional meaning?
Meaning that while the symptoms are very real, often debilitating, doctors usually don't find physical damage or inflammation when they look inside the bowel, say with a colonoscopy. Instead, the root cause often seems to involve a communication breakdown, maybe a malfunction of the sensory nerves in the gut. This leads to these spastic, uncoordinated muscle contractions of the colon.
So the gut muscles aren't working together properly.
Kind of like that. They're not getting the right signals or they're overreacting. And this results in those chronic recurrent episodes of diarrhea, constipation, abdominal pain, and bloating that define IBS.
Our sources list a whole range of contributing factors. It seems quite
It
complex.
is. There could be genetic links, hormonal influences, even immunological factors, plus environmental triggers like smoking, stress a big one, caffeine, dairy, alcohol.
And you often see anxiety and depression mentioned too, right? That gut-brain connection again.
Exactly. It's very prominent in IBS research.
So what do the clinical signs actually look like for someone struggling with this day to day?
Well, when assessing for IBS, doctors look for recurring abdominal pain and distension, that feeling of being swollen. Erratic bowel movements are key. Could be urgent diarrhea, could be persistent constipation, often with unformed stool. Plus that frustrating sense of incomplete evacuation, like you haven't fully emptied your bowels,
Yeah.
and often excessive flatulence, gas. Sometimes mucus in the stool might be present too.
Does it cause weight loss?
Not typically severe weight loss like you might see in other conditions, but fatigue, belching, maybe nausea with meals can definitely occur, all adding to the disruption of daily life.
So what does this all mean for managing IBS? What strategies actually work, according to the research?
Management really needs a holistic approach. Diet, regular exercise, and stress reduction are the foundations. For constipation-predominant IBS, a high-fiber diet is often recommended.
Okay.
But for diarrhea-predominant IBS, sometimes a low-residue diet helps. That means limiting high-fiber foods like raw fruits, certain vegetables, whole grains to give the bowel less work.
So it depends on the type of IBS.
Very much so. But the absolute cornerstone is identifying and avoiding individual triggers. What bothers one person might be fine for another. It requires some detective work.
Right.
Medications can support these efforts too. Things like bulk agents to regulate stool, antidiarrheals for flare-ups, antispasmodics like dicyclamine, brand name Bentyl, is common to calm those gut spasms. Sometimes anticholinergics or even probiotics to try and rebalance the gut bacteria might be used.
Okay, now let's shift gears a bit. From IBS to the inflammatory bowel diseases, or IBDs. And it's really crucial, isn't it, to stress that these are fundamentally different from IBS.
Absolutely fundamental difference. IBS is about functional disturbance, how the gut works. IBD involves actual visible inflammation and physical damage to the bowel wall itself.
Got it. Our sources really dig into two main forms, ulcerative colitis and Crohn's disease. Let's tackle ulcerative colitis first.
Okay, ulcerative colitis or UC. The critical thing to understand here is that it involves recurring ulcerations and inflammation, but specifically of the superficial lining the mucosa and only in the colon.
Only the colon.
Only the colon. It characteristically starts down in the rectum and then can spread continuously upwards, sometimes involving the entire colon. As that inflammation progresses, little pockets of infection, abscesses, can form. They produce pus, what we call purulent drainage. This causes the colon's protective lining to shed and break down, and that leads to those painful ulcerations.
And it's more common than Crohn's.
About twice as common, yes.
The symptoms you described earlier sound incredibly severe for UC.
They can be. Our sources describe patients experiencing maybe 15 to 20 liquid stools per day.
20? Wow.
Yeah, and often visibly containing blood, pus, or mucus. There's typically severe abdominal cramping, often felt specifically in the left lower side of the abdomen, plus persistent rectal bleeding and that profound sense of urgency we talked about.
And you mentioned a serious complication.
Yes, toxic megacolon. That's where the colon becomes extremely distended and inflamed, so much so that it's at high risk of perforating or bursting. That's a life-threatening emergency.
So who gets UC? Are there known risk factors?
Contributing factors often include a family history. Onset is typically in young and middle adulthood, and there seems to be a higher prevalence among individuals of Caucasian ethnicity. Diagnosis often involves barium studies, but the gold standard is really a colonoscopy to see the inflammation directly. And checking stool samples for occult blood, hidden blood, is also common.
And management, beyond symptom control.
Management is multifaceted. It starts with medications like sulfonamides and corticosteroids to get that severe inflammation under control. Antidiarrheals help manage the symptoms. Antibacterials might be needed if there's infection, and newer biologic drugs, immunomodulators, are used to target the underlying immune response.
What about diet and other daily interventions? That must be incredibly challenging to navigate.
Hugely challenging. Diet-wise, patients are usually strongly advised to avoid common triggers, milk products, spicy foods, NSAIDs like ibuprofen, aspirin, alcohol, fried foods, acidic foods. These can all make symptoms worse.
So what can they eat?
Often, a high-protein, high-calorie, but low-fiber diet is recommended during flares to give the inflamed bowel a rest. In very severe cases, sometimes total parenteral nutrition, or TPN, is needed. That's where all nutrients are given intravenously, bypassing the gut completely.
Wow.
Increased fluid intake is vital, and meticulous stress control too. Stress is a well-documented trigger for UC flare-ups.
And our sources also detail some pretty significant surgical interventions for UC, which really speaks to how severe it can get.
Yes, absolutely. For cases that don't respond well enough to medication, surgery becomes an option. This can range from a colon resection, removing part of the colon and creating a colostomy, which is an opening on the abdomen to divert waste.
Right, the stoma bag.
Exactly. Or it could be more extensive. A proctocolectomy removes the anus, rectum, and the entire colon. This requires a permanent ileostomy, where the end of the small intestine, the ileum, is brought to the surface. There's also a procedure called ileoanal anastomosis, or J-pouch surgery, that removes the colon but connects the small intestine down to the anus, preserving bowel function to some degree.
And the cock pouch.
The cock pouch is a type of continent ileostomy, an internal pouch created from the ileum with a valve, giving the patient more control over emptying.
Before any of these major surgeries, there's the bowel prep. What does that involve?
Ah, yes. The bowel prep is essential. It involves a clear liquid diet for a day or two, then drinking large volumes of strong laxatives like Golightly. Often antibiotics like neomycin are given too. The whole goal is to thoroughly cleanse the bowel, reduce bacteria, and prevent serious post-operative infections like sepsis.
And beyond the physical prep.
Crucially, supporting the patient emotionally is vital. Dealing with potential body image changes, the grief of losing normal bowel function, it's a huge adjustment. That support is a critical part of care.
That is an immense amount to take in for ulcerative colitis.
Let's move now to Crohn's disease. How does it really differ, given they're both IBDs?
Okay, Crohn's disease. The stark contrast to UC is this. Crohn's involves inflammation, fibrosis, or scarring, and thickening of the bowel wall that can occur anywhere along the entire digestive tract.
Anywhere. From mouth to anus. Anywhere. While it often appears in patches, skipping areas of healthy bowel, it most commonly affects the terminal ileum, the very end of the small intestine. But its ability to strike anywhere, and the fact that the inflammation often penetrates deeper into the bowel wall, not just the superficial lining like you see, are the key differentiators.
Okay, so location and depth of inflammation, those are the big differences. What about the symptoms then? Are they similar to UC?
Somewhat similar, but with key differences noted in our sources. Patients typically experience fewer stools daily than in severe UC, maybe 3-4. These stools might contain mucus or fuzz, but usually no visible blood, which is a common feature of UC flares.
No blood. Interesting.
Patients often report pain, typically in the right lower abdomen, closer to where the terminal ileum is. If the inflammation affects the upper part of the small intestine, the duodenum, you can get steatorrhea, that's excess fat in the feces due to malabsorption.
And other complications.
Anal fissures, those small tears, and fistulas, abnormal tunnels from the bowel out to the skin or another organ, are much more common in Crohn's than you see. And because it can affect the small intestine when nutrient absorption happens, malabsorption leading to significant electrolyte and acid-base imbalances is a major concern.
What about risk factors for Crohn's? Similar to UC.
Some overlap.
Mm-hmm.
Family history is a factor again. There's ongoing research into potential links with bacterial infections. Smoking is a known, significant risk factor for developing and worsening Crohn's.
Smoking worsens it.
Definitely. And it often presents in adolescents or young adults, which adds another layer of challenge.
And the management for Crohn's, especially thinking about diet when the inflammation could be anywhere.
Diet is exceptionally crucial, maybe even more so than in UC sometimes because of the malabsorption risk. Our sources highlight the use of something called an elemental diet during flares. This is basically a liquid food formula where all the nutrients are pre-digested, broken down into their simplest forms, amino acids, simple sugars, electrolytes.
So it gives the bowel a complete rest.
Exactly. It's residue-free, meaning it leaves almost no waste behind. This allows the inflamed bowel, wherever it is, the ultimate rest and chance to heal. It can actually induce remission in a very high percentage of cases, around 90% according to the data.
That's incredible. What should patients avoid?
Strict avoidance is key. Lactose-containing foods, gas-producing brassica vegetables, think cabbage, broccoli, asparagus, caffeine, beer, MSG, highly seasoned foods, fizzy drinks, fatty foods, and things like seeds and nuts are generally off limits, especially during flares.
And medications.
Medications overlap with UC in some ways. Corticosteroids for flares, sulfonamides, immunosuppressants to manage the immune response, antidiarrheals, antispasmodics. Interestingly, some sources mention using enteric-coated fish oil capsules for their potential anti-inflammatory effect.
And surgery for Crohn's.
Surgery for Crohn's is usually more conservative than for UC, if possible. It's typically a segmental resection, meaning they only remove the specific diseased portions of the bowel, preserving as much healthy bowel as possible because the disease can recur elsewhere.
Okay, we've covered a huge amount on both UC and Crohn's. Could you just quickly nail down the absolute most significant similarity and the most significant difference for us, just to really cement those key insights?
Certainly. The most significant similarity, and this is a crucial takeaway from all the sources, is that both conditions are profoundly exacerbated by stress.
Stress makes both worse.
Absolutely. Managing stress is a vital shared component of living well with either IBD. The most significant difference: location and depth. Ulcerative colitis is strictly confined to the colon and rectum, affecting only the superficial lining. Crohn's disease may occur anywhere along the GI tract from mouth to anus and typically affects the full thickness of the bowel wall.
And confirming the diagnosis.
A colonoscopy with biopsies, particularly from the terminal ileum and colon, is key. They look specifically for microscopic formations called granulomas. If granulomas are present, that confirms Crohn's disease.
Right, let's pivot now to another set of intestinal challenges. These involve more mechanical or structural issues or other specific acute conditions. Let's start with diverticular disease and diverticulitis.
Okay. Diverticular disease is about the formation of diverticula. These are small, outward bulging pouches that develop in the wall of the large bowel.
Like little pockets forming.
Exactly like little pockets. Very common, especially as people age. Now, when one or more of these pouches becomes inflamed, that's diverticulitis. This often happens because tiny bits of fecal matter get trapped in a pouch, causing irritation or even a tiny perforation.
Ouch!
Yeah, and this inflammation can cause painful abscesses. It can even narrow the colon lumen, the passageway, potentially leading to an obstruction.
What factors contribute to this, and what should people look for if they suspect diverticulitis?
Contributing factors often include aging. A history of chronic constipation straining increases pressure in the colon, and a diet that's traditionally low in fiber but high in fat and red meat seems to play a role. Clinically, when diverticulitis flares up, patients typically get an acute onset of pain, usually in the left lower quadrant of the abdomen,
Left lower side, okay.
often
Yeah.
accompanied by nausea, vomiting, fever, chills, and sometimes a rapid heartbeat, tachycardia.
And the management strategy. Our sources seem pretty clear on the do's and don'ts here.
Exactly. Medical management is heavily focused on diet, especially during an acute flare-up. It's critical then to avoid foods with small, indigestible bits like seeds, nuts, raisins, and kernels like popcorn. The thinking is these can get trapped in the diverticula.
Makes sense.
During a bad flare, bed rest and NPO, nothing by mouth are often necessary. Hospitalization might be needed for IV fluids, antibiotics, maybe an NG tube to decompress the bowel.
And long term, to prevent it coming back.
Long term, after the acute phase is over, the recommendation flips. A high-fiber diet becomes crucial. Think beans, bran, fruits, green vegetables. Plus, ensuring plenty of fluids, like 3 liters a day, helps keep stool soft and prevents straining.
And surgery.
Surgical intervention might be needed for serious complications, like a perforation, a persistent abscess, or an obstruction that doesn't resolve.
Our sources mentioned a specific surgical procedure here for severe cases. Hartmann's pouch, what exactly is that?
Hartmann's procedure, or pouch, it's a significant surgical intervention usually done in emergencies. It involves resecting or removing the diseased section of the descending colon, often the sigmoid colon, where diverticulitis is common. The healthy upper part, the proximal colon, is then brought to the abdominal surface to create a temporary colostomy.
Okay, temporary diversion.
Exactly. It diverts the fecal stream away from the inflamed healing area downstream. The lower part, the distal portion of the colon, or rectum, is temporarily sealed off, creating that pouch. The idea is to allow the lower bowel to heal completely without irritation from passing stool. Then, often months later, a second surgery can be done to reconnect the two ends, reversing the colostomy.
Got it. Crucial for letting the bowel recover.
Precisely.
Okay, moving to something acutely critical, peritonitis. What's the absolute standout red flag symptom here, the one that screams emergency.
Yeah, peritonitis is serious. It's inflammation of the peritoneum, that lining of the abdominal cavity. And the absolute key clinical sign, the one you really look for, is a rigid board-like abdomen.
Board-like.
Meaning it feels incredibly hard and tense when you touch it. It's not just tender, the muscles are completely rigid. This is usually accompanied by severe, diffuse abdominal pain, often worse with any movement, nausea, vomiting, and extreme tenderness to touch.
And patients often adopt a specific posture, right? To try and ease the pain.
Yes, they absolutely do, instinctively. They often lie very still, usually on their back, supine, with their knees flexed up towards their chest.
Why does that help?
It helps to relax the abdominal muscles just a tiny bit, reducing tension on the inflamed peritoneum. Other signs. The abdomen might sound hollow or drum-like when tapped. We call that tympanic, due to trapped gas. And critically, you might hear an absence of bowel sounds through a stethoscope. The gut has often just shut down.
Sounds grim.
It is. You'll also see chills, weakness, a weak, rapid pulse, fever, low blood pressure, hypotension. It's usually caused by an infection spreading into the peritoneum, often from a puncture wound, bloodstream infection, septicemia, or most commonly, a rupture somewhere in the GI tract, like a burst appendix, a perforated ulcer, or a ruptured diverticulum.
And management is urgent.
It's extremely urgent. Positioning the patient in Fowler's or semi-Fowler's position, sitting up slightly, can help gravity localize the infection somewhat. NPO status, aggressive IV fluids and antibiotics, often an NG tube for decompression, oxygen support, and prompt surgery to find and repair the underlying cause are all essential.
Let's discuss intestinal obstruction next. Sounds pretty self-explanatory, something blocking the gut.
Exactly. Intestinal obstruction just means that the normal flow of contents through the GI tract is blocked, either partially or completely. And it falls into two main categories. First, there's mechanical obstruction. This is caused by a physical blockage.
Like what?
Think of things like adhesions, bands of scar tissue that can form after surgery and kink the bowel, or tumors growing into the bowel, impacted feces, intussusception where one part of the bowel telescopes into the part next to it, common in kids, or volvulus, where a loop of bowel twists on itself, cutting off its own blood supply.
Okay, so a physical barrier. What's the other type?
The other type is non-mechanical obstruction, often called paralytic ileus. Here, there's no physical blockage. Instead, it's a neuromuscular problem, where the bowel muscles just stop working, they lose their peristalsis.
So the movement stops.
Right. The bowel becomes distended with gas and fluid, you hear absent bowel sounds, but there's no actual physical thing blocking the way. This often happens after abdominal surgery or with certain electrolyte imbalances or medications.
So understanding that difference mechanical versus non-mechanical must be critical for treatment.
Absolutely critical. Management starts similarly for both elevate the head of the bed to ease breathing, keep the patient MPO, regularly measure abdominal growth to monitor the distension. An NG tube connected to suction is often crucial to decompress the bowel, removing trapped gas and fluid. And restoring fluid and electrolyte balance is vital because a lot of fluid can get trapped in the obstructed bowel.
What about pain relief?
Interestingly, our sources highlight that non-opioid analgesics like acetaminophen or NSAIDs, it's appropriate, are often preferred.
Why not opioids?
Because opioids can actually slow down intestinal motility even further, potentially worsening the ileus or masking signs of a worsening mechanical obstruction.
Ah, okay. And the definitive treatment?
Well, for paralytic ileus, it's often supportive care, NPO, NG tube, fluids, while waiting for bowel function to return. But for a mechanical obstruction, surgery is almost always required to remove the blockage, whether it's cutting adhesions, removing a tumor, or untwisting a volvulus.
Okay, our sources highlight appendicitis next, a very common emergency, one many people have heard of, maybe even experienced. What's the classic telltale sign here?
Right, appendicitis, inflammation of that little worm-like appendix pouch attached to the large intestine, usually caused by its opening getting blocked, often by stool or swollen tissue, leading to bacterial overgrowth, typically E. coli. The classic hallmark sign is rebound tenderness over the right lower quadrant of the abdomen.
Rebound tenderness.
Meaning it hurts more when you press down gently and then quickly release the pressure, rather than during the pressing itself. And this tenderness is usually pinpointed at a specific spot called McBurney's point.
Where's that exactly?
It's roughly halfway between the navel, the umbilicus, and the pointy top part of the right hip bone, the right iliac crest. Pain right there, especially on rebound, is highly suggestive of appendicitis.
And it's crucial to diagnose it early because if it ruptures...
It causes peritonitis, which we just discussed is a major emergency. So early appendectomy, surgical removal of the appendix, is the standard treatment.
So what are the really critical preoperative instructions, things people absolutely must know or avoid while waiting for diagnosis or surgery?
This is a really important point for patients and caregivers. If appendicitis is suspected, the patient is kept NPO nothing by mouth in case surgery is needed quickly. Comfort measures for pain are fine, like positioning, but critically, no narcotic analgesics should be given
Why no strong painkillers?
because they can mask the symptoms. If the pain suddenly disappears, it might mean the appendix is ruptured, but the painkillers could hide that crucial change, delaying diagnosis of peritonitis.
Okay, that makes sense. What else?
Most importantly, no heat should ever be applied to the abdomen. No heating pads, no hot water bottles.
Why no heat?
Heat increases blood flow and inflammation, and it can increase the risk of the inflamed appendix rupturing.
Wow, okay, no heat.
And similarly, no enemas or laxatives should ever be given,
Why not those? Seems counterintuitive if something's blocked.
because enemas and laxatives stimulate peristalsis, those muscular contractions of the bowel. If the appendix is inflamed and ready to burst, increasing bowel activity significantly increases the danger of rupture. It's absolutely contraindicated.
Okay, NPO, no narcotics, no heat, no enemas laxatives. Got it. Crucial points. Now to external hernias. What are we looking at here, fundamentally?
External hernias basically involve the protrusion of an organ, usually bowel or fatty tissue, what we call a viscus, through an abnormal opening or just a weakened area in the muscle wall that's supposed to contain it.
So something bulging out where it shouldn't be.
Exactly. These can be congenital, meaning you're born with a weakness, or acquired over time due to things like straining, heavy lifting, obesity, or previous surgery. They typically appear as a noticeable bulging mass, often in the groin area, inguinal or femoral hernias, or around the belly button, umbilical, or at an old incision site, incisional.
So while it might just look like a bulge, our sources emphasize there can be some really serious complications. What are those key risks we need to know about?
Yeah, the bulge itself might just be uncomfortable, but the complications are the real worry. The two critical ones are incarceration and strangulation.
Incarceration.
Incarceration means the herniated tissue gets trapped outside and cannot be pushed back in or reduced manually. This is a problem because the trapped bowel can become obstructed, blocking the flow of intestinal contents.
Okay, trapped and blocked, what's strangulation?
Strangulation is the really dangerous one. This is when the trapped hernia contents, usually bowel, get squeezed so tightly that their blood supply is cut off.
Oh, no blood flow.
Exactly. No blood flow, and intestinal flow is also completely blocked. This causes the trapped tissue to start dying very quickly, leading to gangrene and potentially releasing dangerous toxins and bacteria.
So that's an emergency.
An absolute surgical emergency.
Yeah.
Strangulation requires surgery ASAP immediately to release the trapped tissue, restore blood flow if possible, and remove any dead bowel to prevent life-threatening infection.
What about less urgent hernias? Can they be managed without surgery?
Sometimes. If a hernia can be easily reduced, pushed back in, and isn't causing symptoms, a supportive garment called a truss might provide temporary relief by holding it in. But often, especially if it's symptomatic or enlarging, surgery, known as herniorrhaphy or hernioplasty, using mesh, is required to repair the weakened area definitively and prevent those dangerous complications.
Let's move now to a more serious topic, cancer of the colon. Our sources state it's the second most prevalent internal cancer in the U.S. What really contributes to this?
Yeah, it's unfortunately very common. Our sources point to several key contributing factors and risks. Having a history of chronic inflammatory bowel disease, particularly ulcerative colitis, significantly increases the risk over time. Same for diverticulosis and the presence of colon polyps or adenomas. These benign growths can sometimes turn cancerous.
So those pre-existing conditions are important. What about lifestyle?
Lifestyle factors definitely play a role according to the research. A diet that's decreased in bulk, meaning low in fiber but high in fat intake, particularly red and processed meats, is strongly linked. There's also research looking into the role of increased bacterial counts or specific types of bacteria in the colon.
Okay. What should people be looking out for in terms of symptoms, especially those subtle early warnings?
Clinical signs can often be insidious, developing slowly, but the major red flags include any persistent change in bowel habits.
Like what kind of change?
Could be new constipation, new diarrhea, a change in the caliber or shape of the stool, feeling like the bowel doesn't empty completely. Anything that's different and persists. And crucially, rectal bleeding, whether it's bright red blood or darker, altered blood mixed in the stool.
Any blood needs checking out.
Absolutely. Other signs might include persistent abdominal pain or cramping, bloating, unexplained weight loss, fatigue, and eventually cachexia. that severe weakness and muscle wasting seen in advanced cancer.
The diagnostic recommendations seem quite specific for screening, which sounds vital given how serious this is.
Yes, early diagnosis makes a massive difference in outcomes for colon cancer. That's why screening is so important. Colonoscopy is considered the gold standard for screening. Our sources recommend it as a baseline, perhaps starting at age 30 if there's a strong family history of colon cancer or certain genetic syndromes. For average risk individuals with no family history, screening typically starts later, often recommended around age 45 or 50 now, though guidelines can vary slightly.
And other screening tests.
Yes, regular stool tests to check for occult blood, that hidden blood we mentioned, are also a very important and less invasive screening tool used between colonoscopies, or for those unable to have one.
What about management if cancer is found, especially thinking about surgical options?
Management is usually multimodal. It often involves a combination of radiation therapy and chemotherapy, depending on the stage and location of the cancer. But surgery is frequently a key component, often the primary treatment for localized disease. This can range from removing the cancerous segment of the colon and then rejoining the healthy ends, called a resection and anastomosis. Or, if the cancer is very low in the rectum, it might require a more extensive operation called an abdominoperineal resection, or AP resection. This involves removing the rectum and anus entirely, which results in a permanent colostomy.
That sounds like a huge life change, requiring a permanent colostomy.
It absolutely is, and this raises that crucial point again about patient support. Initiating ostomy care education early, creating a safe space for patients to express their fears and concerns, and supporting them through the grieving process for loss of normal function and dealing with body image changes. These are all absolutely critical elements of comprehensive cancer care. It's not just about the surgery itself.
Okay, finally, let's just quickly touch on a few other common, though often less severe, conditions mentioned in the sources. Hemorrhoids, anal fissures, and anal fistulas.
Right. These are common problems affecting the very end of the digestive tract. Hemorrhoids are essentially varicose veins, swollen, dilated veins in the rectal area. They could be external, visible around the anus, or internal, higher up inside.
What causes them?
Often caused by increased pressure in that area. Things like straining during defecation due to constipation, chronic diarrhea, pregnancy, obesity, even prolonged sitting can contribute.
And the symptoms.
Symptoms can include painless, bright red bleeding with bowel movements, often noticed on the toilet paper, also itching, what we call pruritus, and they can become quite painful if they thrombose, meaning a blood clot forms inside the hemorrhoid.
How are they managed?
Management usually starts conservatively, high-fiber diet and stool softeners to prevent straining, topical treatments like hydrocortisone creams or analgesic ointments for discomfort. Soothing sitz baths, just sitting in warm water, can help too. If these don't work, various procedures like rubber band ligation or even surgical removal, hemorrhoidectomy, might be needed.
Okay. What about anal fissures?
Anal fissures are small linear tears or ulcerations in the skin lining the anus, usually very painful, especially during bowel movements, often with a little bright red bleeding, typically caused by trauma from passing a large, hard stool. The good news is they often heal spontaneously with measures to keep stools soft and perhaps some topical creams.
And anal fistulas, they sound different.
They are different. Anal fistulas are abnormal tunnel-like openings connecting the inside of the anal canal to the skin outside near the anus. They often result from a previous infection or abscess in that area that didn't heal properly. They're also particularly common in people with Crohn's disease, as we mentioned earlier.
And treatment.
Fistulas usually don't heal on their own and typically require surgical treatment to close the abnormal tract.
Wow. We have truly taken a deep dive today into the fascinating, sometimes complex, sometimes profoundly challenging world of intestinal disorders. From understanding that strange paradox of C. diff actually thriving after antibiotics, to really getting clear on the differences between chronic conditions like Crohn's and ulcerative colitis, and exploring everything from acute emergencies like appendicitis and peritonitis to the absolute critical importance of colon cancer screening. We've really unpacked a wealth of information.
Yeah, we connect this all back to the bigger picture. It really highlights the incredible complexity and, the interconnectedness of our digestive system and how that impacts our whole body. Each one of these conditions has its own unique way of presenting, its own distinct risk factors, and often very specific management strategies. It just reinforces how important it is to really listen to our bodies, pay attention to changes, and seek appropriate, timely medical care when something feels wrong.
So what does this all mean for you, our listener? Perhaps it's a newfound appreciation for the incredible resilience of the human body, especially those often unsung heroes working away in your gut every day. Or maybe it's just a crucial prompt to consider that connection, the one we often overlook between our diet, our lifestyle, our stress levels, and our overall intestinal health. It's a reminder that sometimes small choices really can have big impacts down the line. Keep that curiosity alive, stay informed, and keep